Hello, my name is Mike Loria, and welcome to The Pressure is Killing Me, Why Critical Care Transport Crews Should Be Starting Arterial Lines. So, by way of background, I started out in EMS in 2001 and started out as an EMT firefighter. I enlisted in the Air Force in 2005 and was a pararescueman doing combat search and rescue and providing direct action medical support to various teams around the world. I got out in 2011 and started flying for the Dartmouth-Hitchcock Advanced Response Team as a critical care paramedic, and eventually found my way back to medical school. And following that, I did residency and emergency medical services fellowship at the University of New Mexico, and actually stayed for critical care fellowship in the ICU. I continued to work as the associate medical director for Lifeguard, our air medical program, and just cannot get away from flying. So, by way of disclosures, I am the associate medical director for UNM Lifeguard, and I'm the chief medical director for FlightBridge Ed, a company that provides critical care education to flight paramedics, nurses, and other people involved in critical care transport. I have no other financial disclosures. I do want to make sure I make it clear that what I'm discussing here is based on my practice. It's evidence-based and evidence-informed. It's also based on our institutional guidelines and those at our air medical program. I will remind people that you always need to adhere to your local guidelines and protocols for specific therapies and what you can and cannot do as far as treating people. So without further ado, this talk is on arterial lines, or why I really think that air medical crews, critical care transport crews, should be able to start arterial lines under certain circumstances and with some patients. So I want to start out by talking about the general indications for invasive arterial pressure monitoring, some of the limitations of non-invasive blood pressure cuffs, and then talk about specific clinical situations in transport that may benefit from invasive arterial pressure monitoring. And finally, talk about the safety and feasibility in transport, specifically the safety and feasibility of non-physicians doing this procedure, especially outside the hospital. So let's talk about general indications for initiation of invasive arterial pressure monitoring. Well, it's always all about the pressure. Numerous clinical guidelines put out there by various societies and professional organizations have recommendations on where, based on a patient's pathology, we should be maintaining their blood pressure. Often their mean arterial pressure, but sometimes their systolic and diastolic blood pressures. And those can be very important because sometimes those pressure guidelines or those pressure ranges are associated with patient outcomes, specifically worsening or improved mortality and morbidity, as it would be. And some of those that are probably most relevant in critical care transport include things like ischemic stroke and intracranial hemorrhage, traumatic head injury or trauma in general, and post cardiac arrest and cardiac surgery. All have pretty clear guidelines. The list goes on, but those are just to name a couple. And in general, various societies have put out guidelines that have recommendations about hemodynamic monitoring. So this guideline was put out by the European Society of Intensive Care Medicine and stands out to me mostly because they don't even consider arterial line placement to be invasive hemodynamic monitoring. They consider invasive hemodynamic monitoring to be things like placing pulmonary arterial catheters. They specifically refer to arterial lines, peripheral arterial lines, as minimally invasive monitoring, and essentially the basic standard for hemodynamic monitoring in patients in shock or hemodynamic instability. Our guidelines here at the University of New Mexico also have a number of blood pressure goals, and of course, blood pressure being a surrogate of organ perfusion. Our clinical practice guidelines, out of about 67 some odd clinical guidelines that we have for adults, about 34 of those have specific numbers or specific blood pressure goals that we want people to maintain. On a side note, especially with some of our patients that we end up transporting, arterial lines are recommended by the Society of Critical Care Medicine for frequent blood draws or blood gas analysis, and that's fairly common with some of the patients that we end up transporting, especially on longer transports. Some of our ECMO patients or DKA patients, when you're continually monitoring their electrolytes, will require repeated blood draws. So let's get down to it. Do arterial lines actually save lives, though? Is there evidence to suggest that arterial lines actually decrease mortality and morbidity? And the procedures in and of themselves don't. So there's no evidence that suggests that placing an arterial catheter will actually improve a patient's outcome. But that's somewhat misleading and not the entire story. First of all, there are a lot of diagnostic procedures that we find that have significant utility to guide therapy, but don't necessarily in and of themselves improve outcomes. In fact, sometimes they tell us what not to do, and that's okay. Furthermore, in a population that's very, very sick to begin with, these patients are in shock, they're hemodynamically unstable. It's difficult sometimes to demonstrate the benefit of a specific diagnostic procedure because it's a very sick population to begin with. But I'd like to take an opportunity to point out something here, which is that there's also no strong evidence for other things that we use on a regular basis that intuitively have benefit, and we do. So, for example, you know what else doesn't have clear evidence that it actually improves outcomes or prevents injury is parachutes. So there's no conclusive evidence that suggests that parachutes will actually decrease injury or death in the setting of free fall skydiving. And it's actually been studied, believe it or not. Parachute used to prevent death and major trauma related to, this is my favorite, gravitational challenge, a systematic review of randomized controlled trials. It turns out there were none. The authors concluded that there was insufficient evidence to suggest that parachutes actually prevent death or major trauma in this setting. Kind of tongue-in-cheek and published as one of the BMJ sort of funny articles toward the end of the year, December back in 2003. But another group went on to actually try this. So parachute used to prevent death and major trauma when jumping from an aircraft, a randomized control trial. So these authors actually got permission from an IRB to randomize patients to using or not using a parachute. Well, as it turns out, the authors also suggested or concluded that parachutes don't really help prevent death or major trauma. Now, that said, the authors did encounter a significant problem, which was recruitment. So they were unable to recruit or consent anybody to actually be randomized. In other words, no one was crazy enough to say, sure, you can randomize me to not get a parachute and I'll jump out of this aircraft. Again, sort of funny, tongue-in-cheek article. And of course, I'm still going to wear a parachute. I've jumped out of a lot of aircraft, and I will continue to wear a parachute despite the lack of evidence. Now, you know where else there's also no evidence is that specially trained emergency physicians or surgeons or any other medical training specialty can do their job better than other specialties. Or in fact, there's no evidence that would suggest that an emergency physician, board certified emergency physician, is actually better at treating and diagnosing emergency medical conditions better than, say, a janitor or hospital administrator. Now, not to dig on our janitors or hospital administrators, but you can see how silly that is. I would certainly want their help if they were doing their specific job. But when it comes to managing medical emergencies like cardiac arrest, I would want someone specially trained to do that. So I think this is kind of hyperbole, but it's making a point that just because there's no documented evidence, the absence of evidence is not necessarily evidence of absence of clinical utility. And it's getting to an important point in how we study things, which is this idea of equipoise, the balance between beneficence, so doing the right thing for patients by actually studying things and getting to the bottom of things and finding a clear answer to a clinical question versus non-maleficence, in the process not hurting anybody. or providing care that is below the standard of care. And that's really what this is getting to, that a lot of times as essentially a standard of care for our super sick, hemodynamically unstable patients, it is a standard of care, and to a certain extent would not be okay to not establish arterial access and directly measure their pressure very, very closely second to second. And I'll talk a little bit about why that's the case here shortly. But I will stand on the statement that essentially critically ill patients will benefit from close hemodynamic monitoring. Yes, there are complications with it. It's not always that straightforward. But overall, a lot of medications that we provide and interventions that we do are life saving, do in fact um, have significant adverse events and complications associated with them. But overall, we believe that the risk benefit lies in favor of doing the procedure in order to provide some other clinical endpoint. And oh, by the way, there's really no evidence that says making clinical decisions with no data or crappy data is in any way, shape, or form beneficial. So let's now talk about the limitations of non-invasive blood pressure cuffs. So old reliable, the old blood pressure cuff, right? Well, it is, and generally we use this worldwide to very simply and easily measure someone's blood pressure. And in general, if you walk into your primary care doctor's office and you need your blood pressure taken, or we're monitoring your blood pressure long term, absolutely. You're not critically ill, you're not in cardiogenic shock, you're not bleeding to death, and therefore it's completely appropriate under those circumstances. But with our patients that are super sick and critically ill, blood pressure cuffs are neither accurate nor precise. And a lot of that is because of the way the machine actually works, the way it measures a blood pressure. And if you think about it, that air bladder attached to the machine, what the blood pressure cuff is actually doing, in particular, with some of the transport monitors that we use, is it essentially listens for the loudest point where it hears the pulse. And that is essentially the mean arterial pressure, the average pressure in between the diastolic and the systolic pressure. And off of that measurement, it actually does a calculation, has an algorithm that calculates or estimates the systolic and diastolic blood pressure. And that technical way of measuring blood pressure is subject to various limitations and interference from things like noise. Loud noise can literally change or disturb the measurement and give you false readings. Often, we see this in the trauma bay, as when there's a lot of noise around, it can actually be falsely high. It will actually be very or significantly above what the actual blood pressure is when we compare it to either a human listening for the pulse, a manual blood pressure management, or if we put in an arterial line. It's also subject to motion. Not that we experience this at all in air medical transport or critical care transport, but motion plays a significant role in it. And size does matter. I would argue that often we put on the usual adult blood pressure cuff without always thinking, unless we're at extremes of size, little kids or people who the cuff simply will not fit around their arm. We don't always think about the ideal blood pressure cuff size for that patient to get the most accurate measurement, and it does matter under these circumstances. Body position matters as well in terms of how someone is sitting in the relationship of the blood pressure cuff to their heart. Theoretically, based on standard measurements, someone should be sitting with their feet on the ground and their arms, or their arms sort of like this, bent a little bit, sitting in a chair. Our patients aren't always like that. And I would argue that non-invasive blood pressure cuff values do not correlate with invasive measurements, especially with critically ill patients. In fact, in a review of more than 200 patients, where they basically did matched values, they demonstrated a disagreement of more than 20 millimeters of mercury in a little over 25%, so a little over a quarter of the patients in this study, when they simultaneously measured the blood pressure cuff on their arm and compared it to the arterial line in their other arm. Those values were off substantially. That's a really big deal. That's like having a patient where you measure their blood pressure cuff and it says 70 millimeters of mercury is the mean arterial pressure, under which circumstances it's not indicated, for example, in septic patients to do additional things, start pressors, so on and so forth. Often our MAP is generally targeted to above 65. But that difference of 20 would mean that if you put an arterial line, the blood pressure would actually be 50 millimeters of mercury. So off by more than 20 millimeters of mercury, under which circumstance that would significantly change the clinical game, right? We'd be doing a lot of things to try and get their blood pressure up. When we look at patients in the OR that were hypotensive and resuscitated, we see significant difference between um, the non-invasive blood pressure cuff management measurements and the invasive blood pressure cuff measurements, excuse me. And when we actually measure these things and plot them against one another, you can kind of see here, and I'll point this out, the R value on this graph. So this is a plot of invasive blood pressure cuff versus essentially oscillometric blood pressure or the non-invasive blood pressure cuff. And these values were plotted one against another. And what you can see here is the invasive blood pressure cuff on the x-axis and the oscillometric or non-invasive on the y-axis. And the correlation between the two, this R value right here represents the slope of this line. And it's essentially the agreement between the values. In other words, the slope of this line, if it were perfectly 1, that means that as the invasive blood pressure cuff increased by 1 millimeter of mercury, the non-invasive blood pressure or the oscillometric blood pressure would also increase precisely by 1 millimeter of mercury. Anything above essentially 0.7 or 0.75 is a pretty good agreement. But you can see that there are substantial differences between some of the blood pressure cuffs, like here where this blood pressure measures 62 and the oscillometric blood pressure cuff actually measures, or excuse me, the oscillometric blood pressure cuff measures 62, and the actual invasive blood pressure cuff on the y-axis is 56, or actually below 56 here. So it's a pretty substantial difference, right? I would also add we need to be careful because the limit of the agreements here, or the range of acceptable values statistically, is reported somewhere between 56 and the mid 60s, so or just a little over 60. So that's still a pretty significant difference between those two on average. Now, if we plot the data somewhat differently here, what we can see is an interesting trend pop up. So this is actually called the Bland-Altman plot. And what it does, on the x-axis here, you see the average map. So it's the average of the two values between the invasive and the oscillometric blood pressure cuff or non-invasive blood pressure cuff. So let's just say that the invasive blood pressure measured a map of 50, or in this case, we'll say 56. And the invasive blood pressure actually, or excuse me, the non-invasive blood pressure actually measured 76. So under those circumstances, you would have an average of the two. So the average of 56 and 76, which would be somewhere right around 66, and the y-axis is the difference between the two. So the invasive minus the non-invasive. So if it was 56 is the invasive measurement, and 76 is the non-invasive blood pressure cuff measurement, it would be a difference of about -20. So the x-axis would plot somewhere right around here, around -20. And what you can see here then, we plot all the values that were measured in this study, an unfortunate trend appears, which is that, first of all, you can see the mean difference is about 5.4, but there's a really big spread here, about -8.5, so almost -9 millimeters of mercury to almost 20 millimeters of mercury. And what's even more concerning is exactly what we don't want to see. In other words, when we have a super hypotensive patient or someone with very low blood pressure, the oscillometric blood pressure tends to be greater than the invasive blood pressure, and that's why these values are negative. In other words, the blood pressure cuff overestimates the blood pressure for patients that are very hypotensive, and on the high end, it it actually underestimates the blood pressure for patients with very high mean arterial pressures. So, like a stroke patient with a super high blood pressure, it will underestimate that patient's blood pressure. That's not good. But what about patients in critical care transport? Those are patients in the OR and the ICU, but what about critical care transport? Well, as it turns out, it doesn't get any better in transport. When we start rocking and rolling and with the loud noise that patients are exposed to, those differences become even more pronounced. In other words, the spread varies even more now, up to about 24.6, almost 25 millimeters of mercury, or negative 23 millimeters of mercury. So that's a spread of almost 50 millimeters of mercury between these two. It looks like someone took the choke out of their 12 gauge shotgun and plugged away at this piece of paper. There's very poor agreement between these values, even though the average is about zero point 0.5. The spread is tremendous, which demonstrates, I would suggest, poor agreement between these values. So essentially, the way I think of it is if you have someone who's very sick, very dynamic patient who you're active resuscitating, pushing medications, giving push dose pressors, hanging drips, doing all sorts of stuff, if you are just using a blood pressure cuff to guide your therapy under those situations, essentially like driving down the highway at 65 miles an hour with your eyes closed, and every 2 to 3 minutes, whenever you decide to take a blood pressure or have the blood pressure cuff set to, you open your eyes really quick, see where you're going, and then close them again. In fact, an even better analogy would be like when you open your eyes, actually trying to drive forward by looking in the rearview mirror. Because remember, that blood pressure cuff took the pressure about 20 to 30 seconds ago. So it's not super helpful. Not super helpful. Now, let's talk briefly about the clinical situations in transport that may benefit from invasive arterial pressure monitoring. People ask me all the time, so when do you actually do it, Mike? If you can put in um, arterial lines as a physician, when do you actually do it? And the answer is I don't always do it on every hypotensive or every hypertensive patient. But here are my criteria. First of all, obviously, they need to be critically ill with hemodynamic instability. So, yes, they do need to have really high or really low blood pressures. But more importantly, and actually this should probably be number one on the list, is there is no critical time sensitive intervention that needs to be achieved. In other words, when I know that a therapy is known to help patients by saving time, that quick and expedient transport is the way to go. I would never wait at an outside hospital to start an arterial line. I might start it en route while we're flying, but I would never withhold or delay evidence-based other evidence-based therapies, specifically time-sensitive therapies. So getting a STEMI to cath lab, or getting a stroke to thrombectomy, or getting a patient with intra-abdominal hemorrhage to a surgeon. I would never ever delay one of those things to start an arterial line. Also, the blood pressure cuff, I will do it when a blood pressure cuff is not accurate or clinically correlating. So when the patient is pale and mottled and the blood pressure cuff is on their arm and suggests that their blood pressure is 140 over 80, I would say that that blood pressure cuff does not appear to be clinically correlating with this patient who is super, super sick, and that would indicate that they may need more accurate monitoring, or if it's not precise. In other words, the blood pressure is kind of bouncing all over the place. It's, the map. 1 minute you get a map of 52, and the next minute the map is 91, and then the map is 65, and then it's 82, and it's just bouncing all over the place. It really can't guide my therapy very well if it's all over the place and difficult to pin down, and I'm stopping pressors and starting pressors and doing other stuff. I do take into account the time to destination. It does seem a little silly to me sometimes if you're, even if it is indicated, if you're 10 minutes away from the receiving hospital or the interfacility transport that you're doing, the facilities are actually very close together. And let's just say you're driving 10 minutes down the road from one facility to another that can offer a specific therapy. Um, that may not be beneficial under those circumstances. There are some times when it pops in my head that it may actually be very well indicated and very helpful. So I've definitely been at the bedside and sending facilities for minutes to hours sometimes with very, very unstable patients that we are actively trying to stabilize and still transport because we believe there is utility and potential benefit in getting them to the receiving facility for some intervention. These peri-arrest patients that are super unstable or kind of going in and out of cardiac arrest, stuttering cardiac arrest, can be super, super helpful because you can directly see a blood pressure and see if there's a perfusing rhythm instead of people standing around and trying to palpate every artery in the patient to decide do they have a pulse, do they not have a pulse. Invasive arterial monitoring will tell you right away. And although that is not directly linked to improved patient outcomes, what we know is that it is helpful to determine things or guide therapy that is. So, for example, there's lots of studies that showing that limiting the pulse checks or limiting time off the chest is really important. Whereas instead of standing around and guessing if the patient actually has a pulse, you can immediately just look up at the arterial line and say, oh, they have no pulse. That arterial line we did have a waveform when we were doing chest compressions. We stopped chest compressions and it went flat. This person is in fact pulseless and get right back on the chest. Not to mention the fact that there are good studies that showing that we are not very good at detecting pulses sometimes. So it's a useful tool under those circumstances. Other things, so advanced therapies or mechanical circulatory support, specifically ECMO, I believe these arterial lines are absolutely essential, both for looking for things like differential hypoxia and continually invasively managing or measuring blood pressure is very important. Looking for pulsatility, the list goes on and on. So I think it is absolutely essential under these circumstances. Again, I will harp on this very important point that I will not and I do not encourage my crews to delay other evidence-based therapies just to start an A-line. Get going, do those evidence-based therapies. If you are moving to a critical time-sensitive intervention, absolutely get the patient in the aircraft, get the patient in the ambulance, and start moving to that intervention. You can do it en route, but I would say that staying or delaying transport or delaying those other evidence-based therapies is not okay. Let's lastly talk about safety and feasibility. So I do have some physicians tell me, well, starting an arterial line or poking an artery in general, it can be dangerous. There's complications, and only doctors or providers, highly trained people, should do it. And I'm sorry, but I think that's kind of BS. There are plenty of guidelines that specifically discuss respiratory therapists and nurses and other allied health professionals actually obtaining ABGs and sticking an artery. In fact, our hospital has a policy. I know plenty of other hospitals have policies, and our nurses are amazing. Our respiratory therapists are amazing, and they get ABGs all the time. And when you look at large retrospective cohorts to look for complications, it is very, very low. In all comers, this is generally done by respiratory therapists and nurses, not physicians. The complication rate is very low. It's less than 1%. 0.14% is the complication rate. Now, that's not always insignificant. It can cause significant problems like aneurysms and pseudoaneurysms, nerve damage, even thromboembolism, causing that artery to clot off, and ischemic damage in very, very rare cases. But overall, we think the benefit of actually knowing what someone's pH and arterial oxygen is outweighs the risk of any complication. But you might say, okay, well, it's really putting the cannula in. It's putting the catheter into the artery that's dangerous. And only doctors should do that. Only providers should do that. Well, again, I got to say, this is kind of BS. And my litmus test for this is that let's say you go into the hospital, any academic center or ICU, and where there's residents and interns and fellows, and we go to start an arterial line patient. Well, who are you going to call? Who are you going to get to do it? Often, this is considered a great procedure to start learners with because it is so safe. And now, with ultrasound guidance, again, we can begin to train our interns and residents and fellows and even newer attendings to perform this procedure. So, this is something that we train our interns to do on a regular basis. And this is not disparaging interns or medical students or anybody else in any way, shape, or form. Point being that it is safe enough that we believe that we can guide novice or trainees that are novices when it comes to vascular access to do the procedure. And if we can train our novice physicians to do it, then I believe it is also very reasonable to take our nurses and paramedics who can get blood from a stone and have all sorts of specialty certifications and credentials these days to place midlines and PICCs and do ultrasound guided peripheral IV sticks, which I would actually argue are harder sometimes than arterial cannulation. I think it is very reasonable with their technical level of skill to teach them how to place arterial lines. And it's generally very safe. When you look at large populations, actually cannulating people, so not just doing the ABG, but putting in arterial cannulas, all complications less than 1%, major complications less than 0.09%. And this is another large retrospective review of hundreds of thousands of arterial lines. But what about the field? What if you're a deft and capable retrieval physician or flight physician? How do flight physicians do? Well, in the retrieval environment outside of the hospital, we still do pretty well overall, considering the environment. The overall success rate outside the hospital was about 83%, so almost 85%. And the concern is always time. It takes time to do these procedures, right? Well, as it turns out, it can be done safely and effectively in about 1 to 3 minutes for the cannulation and about 2 to 4 minutes to set everything up. So it's a total time of about 3 to 7 minutes to get this procedure done. So 3 to 7 minutes to know what the blood pressure actually is, given the fact that patients who are hemodynamically unstable, critically ill, or in shock, that non-invasive blood pressure cuff is not accurate. I would say the time is worth it to guide therapy. Now, one group actually did a study of looking at nurses. They took a small group of nurses and trained them to place arterial lines. They looked at 107 attempts. They had a 63.7 first attempt success rate and no complications supported. Now, at first glance, this 63.7% doesn't sound like a really good first attempt success rate, but I think this was a lot of the design of the study. When they did it, they really only gave them one shot because they didn't want the nurses to be trying over and over again. They felt that it was reasonable to have them try once, but if they didn't get it on the first try, it would go to a provider who is more experienced at placing arterial lines. In going back to the 90s, looking at 500 arterial catheters placed by RTs. These catheters were in place in the ICU for anywhere from like 1 to 20 days, I believe, and their overall complication rate was 0.2%. So again, less than 1% all complication rates. And if you looked at serious complications, right? So starting the line having pain at the site, or a hematoma that goes away, or a transient nerve palsy, I wouldn't really even consider that a significant complication. A complication, yes, uncomfortable for the patient, okay, but not a significant long-lasting complication that required any intervention. And if you look at those, it's even less. Now, bear in mind that these studies were actually done before the age of ultrasound. We were training all of our nurses to do ultrasound guided IVs and start midlines and PICCs, and even for the physicians. If you look at physicians placing arterial lines, so specifically in the setting of arterial line placement, when physicians use ultrasound as compared to anatomic guided placement, we know that we're faster by about 3 minutes on average. It takes us fewer attempts, and we poke fewer times, so fewer sites are actually attempted. I would say I cannot prove, but my hypothesis is that those safety margins would be even better nowadays with ultrasound. Now, there's some limitations here. And I gotta be honest with you, when I was a flight paramedic and a provider in the field, I just wanted to go, go, go. I thought it would be awesome to do these cool procedures and it'd be great for our patients. But now I have to actually put on my medical director hat. You got to think about it in the context of things, of other program needs, training, etc. So I got to put on my medical director hat for a second here. First, we can't just go about doing things in a vacuum. We need authorization from the appropriate agencies, including state boards of EMS and nursing and all of the regulatory hoops that we have to jump to get approval for our providers to do this. Training and education is no joke, especially in today's environment where time and money are very limited resources. I would actually recommend that you look very carefully if your organization can manage the time and education needed to do this. Again, I think you can do it safely, but even if you look at those studies, there was a lot of time and resources placed into training those nurses. It takes us as physicians time and energy over the course of years to get really good at placing arterial lines. So, if there are other more important needs in terms of training, time, and education, ideally guided by data, if there are things that your critical care transport service needs more, better education on neonatal resuscitation, better education on obstetric complications, or let's say you're having issues, your first attempt pass rate for airway management and intubation is lower than it has been recently. Those are probably things that are higher yield, and your time and energy and money should be invested there, because the training and education to get a program like this off the ground and train especially a large group of nurses and paramedics to do this is not inconsequential. Quality assurance is another issue. Now, interestingly enough, this is still something that I struggle with. Getting follow-up, making sure that there were no complications from arterial line placements is challenging even at our own institution sometimes. Because if you think about it, they're placed in transport, and arterial lines are placed in transport by our crew. They go to the ICU. No one is specifically screening that patient for complications. And if they go to an outside hospital, it's even harder to track them down and get that information. So we may not be able to provide the same quality assurance that was that these studies looked at. And of course, continuing education. This is again a challenging thing for people. We don't really know how many airways it takes to keep our critical care transport crews current and as competent and sharp and on the ball as they could be. We certainly don't know how many arterial line sticks it takes to stay current and facile with this procedure. We just don't know. So again, at our institution, we're a hospital-based program, so I can take our providers, our critical care transport nurses and paramedics into the emergency department, into our emergency department resuscitation unit where all of our sickest patients go, and of course in our ICU, and they can get great education from our attendings, fellows, APPs, some of our flight residents, one-on-one training that is fantastic, both initially and continuing education. If you can't do that or provide that level of education and training, it may not be a great idea to start this program, and I certainly can't tell you how many you need to do in order to get there. So, in summary, I want to go over a few takeaway points. First, despite the lack of randomized controlled trials, invasive pressure monitoring is a standard of care for critically ill patients, and we should be doing it. We know that non-invasive blood pressure cuff measurements typically used in CCT are neither accurate nor precise in critically ill patients, specifically critically ill patients with exceptionally low or high blood pressures. In real estate, it's location, location, location. And when it comes to procedural medicine and critical care transport, it's about selection, selection, selection. Knowing which patients to do it on, knowing when to perform the procedure and when not to perform the procedure is critical. And finally, I would submit that it is safe and reasonable for non physicians to perform arterial cannulation. So don't be scared. Yes, there are complications that can occur, but in general, with our super sick patients, when we don't know where what their blood pressure actually is, or our non-invasive blood pressure cuffs are not giving us great numbers, accurate or precise numbers, it may be reasonable. So we shouldn't let the potential complications scare us away from a procedure that's benefits may exceed its risks. So don't be scared. Just go out there and be freaking awesome. Thank you guys very much for your time. If you're interested in seeing the references, you can follow this QR code or you can go to this tiny URL, so tinyurl.com CCT Artline, and it will take you to an article that we wrote that goes over everything I discussed in this talk, as well as has the list of references, all 20-something references that we used to make this talk and write this paper. Thank you guys so much for your time and attention. Take care and stay safe out there.